Dr. Ray Onders, the inventor of the brilliant device called a diaphragm pacing system, and he's going to speak to you about that.
Thank you. Well, it's an honor to be here. It's an honor to have met some of our mutual friends. It's an honor to know Steve. And I, like Sarah, had my sister died from ALS about 4 years ago, after I had been an ALS researcher for about 8 years. And so it's a very unfortunate thing to have ALS. What I'll be talking about today is some of my research, and I'm a surgeon researcher. We'll talk about what gadgets or what therapies we have to help patients that are suffering from ALS. I've been working on this for 20 years now, well before my sister having ALS. It's been involved in a lot of animal models. I've been involved with over 1,500 human implants for various diseases. Have a fair amount of peer-reviewed publications. Everything I do is involved in research to try to develop the best aspects for care for ALS patients, to see which techniques will work and which techniques won't work. Nothing we do in ALS, and I'm glad we have a geneticist here talking, every ALS patient is different. And that's why the same therapies will not work for the same patients. It's such a differential disease that it's not all going to work for each patient. I'm just going to review a little bit about diaphragm pacing. I'm going to show something that there's always a concern. If you do surgery right, surgery can be safe in ALS patients. I'm going to outline our results for patients with ALS, and I'll review some of the other things we found over the years, what we call a low-profile, friendly gastrostomy tube. Nobody with ALS wants to have a feeding tube. You'll need it. And some other recent research we've looked at another quality of life issue, something as simple as how can I urinate in public better when I have late-stage ALS. I'll show some videos here, so hopefully you've not eaten dinner yet. But I am a surgeon, so it's good to look at it. And this is just a diagram of how we breathe. I can breathe with my cerebral cortex. Take a deep breath. Most of us breathe in our brainstem, and we don't think about breathing. Both of those are upper motor neurons. Our lower motor neuron for our breathing is in our spinal cord. ALS is the disease of upper motor neuron and lower motor neuron. If you're all what we call lower motor neuron, diaphragm pacing will not work for you at all. We're just trying to help move that diaphragm so you'll move more air. If you're moving more air, you won't need a ventilator. Our goal is to do this earlier. We have some case examples of late-stage ALS, but ideally we want to do this before you go on the ventilator. I like to show this video of what we call a fluoroscopy of a diaphragm. Our diaphragm is a muscle in our chest. That's actually my diaphragm contracting. It's all about moving your diaphragm. If you move your diaphragm, you'll breathe. Our diaphragm has different controls during the daytime and nighttime. And that's why it's so important, why many ALS patients have problems at night. It's because it's a different control mechanism. We're trying to identify that and treat those areas. The operation, it is an operation. It's a real operation. This is an operation on a patient with the disease. We now do it laparoscopically. And I'll kind of go over the steps. I just show this picture here. And I'm sure ALS Worldwide will have all these slides on their website shortly, so that you can look and study them a little bit more. But our goal is to actually just put some electrodes and bypass the lack of control. This is what we can see at surgery. This is somebody's right diaphragm. The liver there is nice and healthy. And you can see no movement on this right diaphragm. I'm using an instrument to try to make it contract. And then I'll go to the other diaphragm. That's a feeding tube on the inside. And you'll see a nice big movement. That's the disease of ALS. It can affect one side but not the other side. This patient's on a ventilator. We can actually get, if one side's moving, that's enough to get off the ventilator. So we did a lot of work on how to identify where to put these electrodes in. You'll see me put the references all throughout the talk about that. And then we use this little needle to put an electrode in. This electrode was developed at my university, a similar one for the nice university I'm here. Mine is in Cleveland, though. The weather here is much nicer than in Cleveland. And you can see we just put the small electrode in. And then you'll see the first one where the first part of the diaphragm contracts, the second part. All we're doing is bypassing the lack of control. It's a relatively simple concept. If the patient can't move the muscle for breathing, we can bypass that with some electrodes. It actually all started with Christopher Reeve, my first patient, Superman. And actually people say, why did I start the research on ALS? Because one of his good friends, Katie Couric, had a friend with ALS and asked me on national TV. And I just published a story of why we started ALS. And as a researcher, somebody asked you a question, we went back to identify, would this work in patients with ALS? And again, our goal in spinal cord injury is to get rid of tracheostomies. Nobody wants a tracheostomy. We did a lot of work on tracheostomies early on to try to identify how we could decrease tracheostomies and change things. One of the things we learned on is if you have a tracheostomy, we use something called a pass-a-mirror valve, which gives one-way flow to try to increase your ability to talk, even if you're on a ventilator. In ALS, if you're on a ventilator, many times with secretions, it's hard to use this pass-a-mirror valve, and sometimes we can. Again, our goal for spinal cord injury was to get rid of the tracheostomy. Our goal in ALS is to prevent ever needing a tracheostomy tube. So in ALS, we really began this research after just 2 patients. And again, you'll hear us all talk. ALS is upper and lower motor neuron. If you're all lower motor neuron disease, diaphragm pacing will not help at all. You have to have an intact motor unit for this to work. And the goal is really to augment respiration. This is not a cure for ALS. This will not make your leg muscles work better, your arm muscles work better. It's purely to help breathing. And as Steve said earlier, most patients with ALS die because they can't breathe. So again, Ravitz, which is an ALS researcher, has shown that ALS can be all lower motor neuron or all upper motor neuron. If you're all upper motor neuron disease, diaphragm pacing will let you live as long as you want to without going on a ventilator. And so unfortunately, we don't know what type of disease you have until after surgery. But if you identify which group of patients, it's patients that are mostly what we call upper motor neuron disease. We did a large trial, which I won't go over all the research in sorts of time, but we did a large multi-center trial with many of the major ALS research organizations in the United States. We identified that we improved survival by 16 months compared to the usual ALS patient. We actually showed something very easily, which I'll talk about shortly, is about the feeding tube. We know that patients with feeding tubes have a high risk of going on a ventilator shortly thereafter. We actually showed in this large study that that just didn't happen. We also realized that patients sometimes can't tolerate the mask breathing with ALS. Diaphragm pacing can work in those patients. We showed an improvement with sleep. And this is unfortunately kind of a survival for ALS, is that this is standard ALS therapies. This is adding diaphragm pacing. Again, it's not for everybody. We're just improving the survival for those patients or delaying the need for a ventilator for those patients with ALS. And again, we have several articles that have showed with the right anesthesia, surgery safe. I mean, we just don't give paralytics. When people have operations, they'll give a paralytic, which is what we don't do. There's ways of doing surgery safely. So I routinely operate on patients that have gallbladder disease, appendicitis, that really were denied therapy somewhere else because they didn't know how to correctly treat the patients with the anesthetic management. This is an article we just published last year, which was my initial pilot trial, which I was finally able to close down that trial because my final patient finally died. And he died because he turned off the device after 6 years of never using anything else. So sometimes people will say, where's these publications? Officially, as a researcher, until every patient finishes the trial, you don't publish your data. And so this is the final one I just published last year. Again, we showed the significant improvement in survival in the group of patients. It's not for every ALS patient. But for certain patients, this just controls their respiration as the disease, unfortunately, ravages the rest of their body. We showed what we call the improvement in muscle strength and muscle size. We can measure the size of the diaphragm muscle, and we can actually show that we can improve the size of a muscle with electrical stimulation. Because once you're not using a muscle, it will atrophy very rapidly. The diaphragm is an incredible muscle where if you go on a ventilator, and sometimes if you go on too early, you will lose half of your diaphragm muscle mass in 24 hours. It atrophies faster than any other muscle. That's why once a patient goes on a ventilator, it's very hard to get back off because of the adverse effects of being on a ventilator on the diaphragm. I have a whole other research project on that aspect for anybody in an intensive care unit. What we saw, and this again goes by the base of what we can do, under that x-ray that I showed you earlier, I can have a patient try to breathe, and then we can turn on the pacer, and we can just make the diaphragm move more than the patient can, which improves their respiration. We showed something else very easily. During our research, we could identify that we can read our implanted electrodes. And sometimes patients just lose their ability to breathe. And the reason people die from ALS, from respiratory failure, is their carbon dioxide level is slowly going up. And that goes up because you're not moving much air. as many people with ALS, and I think on Steve's website they talk about oxygen can cause ALS patients to die very rapidly with ALS, because ALS patients need what we call a little hypoxia to drive their ventilation, because part of their brainstem that controls breathing is based on carbon dioxide. And once your carbon dioxide level starts rising, you kind of lose your ability to move air, and therefore you can very rapidly die. In the US, it would be carbon monoxide poisoning from having a bad furnace. Because your weather is so good here, I doubt you have that here in Greece. In the US, it's always a problem. And we identified what happens. They lose their ability to drive their respiration, and diaphragm pacing can do that for patients. We can actually overcome what we call central sleep apnea. This is a reading of a patient at night, and this is actually during the day. This patient at night obviously was having their diaphragm get weaker every night because they weren't using it. When you turn on the pacer, we drive that diaphragm to work so that it won't get as weak at night. We showed in a publication that diaphragm pacing improves a patient's ability to sleep, again, by maintaining muscle mass and making that patient breathe more regularly at night. Something as simple as an x-ray, which has been one of my big areas. An ALS patient, everybody has problems with breathing, but a simple x-ray, which is one of the most least expensive tests, we can identify problems. I'm sure when you see your neurologist, they check your right arm, your left arm, you can check your diaphragm. You can see a patient here with a bad diaphragm, elevated. The only way you can check that is under x-ray. You can see another elevated diaphragm here. Again, if we see that, we realize the patient may start having breathing problems earlier. Something very simple to identify. Not only that, we can identify why that occurs. None of us could just move one diaphragm. I can move my right arm, my left arm. I can't move one. An ALS patient, as you can see on this x-ray, has an elevated diaphragm, can only move one diaphragm, but we can stimulate both. Therefore, we prevent that diaphragm when it gets elevated. It causes lung collapse, and that lung collapse is what leads to pneumonia. Again, as we look at what we're trying to do with ALS, to identify the lack of control of the diaphragm muscle. I'm going to kind of go on the next aspect, which is a feeding tube. The feeding tube, interestingly, was invented in my hospital in 1979 also. I'm not that old. It was my previous boss, Jeff Ponsky, that invented it. So I like to say our hospital actually has two of the therapies for ALS was invented at, feeding tubes and diaphragm pacing. A feeding tube is important to maintain your nutrition. Many patients don't want to have a feeding tube because you have this large tube sticking out. 1981, Michael Goddard, also in our hospital, a pediatric surgeon, developed the first low-profile button. So we know most ALS patients will eventually need a feeding tube. You'll lose your ability to swallow. You need to eat and maintain your nutrition. And we know many patients don't get a feeding tube. The numbers are in the US, only about 40% of patients do. So we identified why are patients refusing to get the feeding tube. They don't want to look at that large feeding tube. So we actually did a study, and we offered the patients when I realized I could put an immediate low-profile feeding tube. You can see when you're given a choice of of this tiny tube or this long one, which one will you choose? But being a scientist, we asked patients in a prospective fashion which tube they'd want. And again, 114 out of 117 patients I treated last year wanted the low profile. A few reasons not to, based on your size of your body. But again, if a patient wants something and they feel better with it, they'll accept that earlier. You need to maintain your nutrition with ALS. And sometimes, just because you have a feeding tube, you can still eat by mouth, but sometimes it may take an hour to get in a meal. You can at least get your calories in through the feeding tube. So we showed that it can be offered. It's safe to put in immediate low-profile tubes, and it'll help the patient in that respect. Why? We also looked scientifically, why do patients that get diaphragm pacing and a feeding tube have a better result? And it's something called respiratory compliance. If we do both together, we can maintain the diaphragm problems that you would get with just putting in a feeding tube. Respiratory compliance is a sign for the work for breathing. So by adding diaphragm pacing at the same time, you have less work for breathing after the procedure. Therefore, you'll recover quickly from the next operation. One other thing we realized early on when you have a feeding tube, if you have ALS, many times you swallow a lot of air and you don't feel hungry because you'll get this big gastric bubble, as you can see on this x-ray. And one of the things the feeding tube does is relieve the gas. It's actually, as you lose your abdominal muscles, your ability to burp decreases. Sometimes just releasing gas through this tube makes life better for you. You feel more comfortable, you eat better. It's looking at, and it's just taking care of the patients, the quality of life for these patients. One thing we recently started looking in just the last 2 years was something else, that many of our patients, as we saw them living longer from various aspects of all these little therapies, and that's what ALS survival is multiple little therapies so that you can enjoy your life longer. As patients, as they became more bedridden, and it's more common with women whose husbands can't get them to a restroom in a public area. As you can imagine, in the city of Cleveland, it's difficult. In Athens, finding a public restroom is probably even harder, and if people would stay in their house, not enjoy life. We started offering a suprapubic catheter. It's like a feeding tube going into your bladder. It's not anybody wants to talk about these things on a public forum. It's not what you're going to bring up with your neurologist, but it's something we started asking patients for. Once you start asking patients, what would make your life more enjoyable? What would you do? There's problems with the usual aspects of Foley catheters, condom catheters, pads, because it may fall off. Patients just don't like that. And this looked at it. And it is a simple procedure where you just put a catheter directly through your skin into your bladder. It allows the ability that you're just going to be urinating all the time. It's interesting when we ask patients afterwards if they liked it, everybody would say yes. Why didn't anybody tell me this earlier? If you're able to do well on your own, that's fine. But for certain patients, it's a simple thing that it helps. There's benefits of independence. No worry about having somebody help you use the restroom. You're using it. You don't have to worry. I had many patients that would just dehydrate themselves before they'd go out to a museum so that they wouldn't have to find the restroom. Every minute you're fighting with ALS for a motor neuron to live or die. You dehydrate for 5 hours, that motor neuron may die quicker. So by having something to just maintain your continuous nutrition, hydration, will help in our battle of keeping motor neurons alive. Hopefully our next two speakers will have more battles on how to keep those motor neurons alive longer, but it's something that we look at, just something simple of that. And again, it's less worry about accidents, maintaining better hydration, better sleep, not having to call somebody to get up. And again, as we try to treat the ALS patient, it's using all these things together. And actually, I do them all at the same time if you're in my hospital. So we'll have a feeding tube, the low profile, of course, diaphragm pacing, and a suprapubic catheter. So you can do all three at the same time. We had no problems with simultaneous operations for that. So it's just in kind of the suprapubic catheter, one of my newer areas of research. It can be safely performed in patients with ALS. There's a risk for urinary tract infection. That's a known risk. There's no cross-contamination or problems doing it at the same time with other procedures. Overall, though, when we look at what diaphragm pacing can do, we've shown it can work in the right ALS patient at the right time. It's not for everybody. It will not work in everybody. And I'll be the first one to say I see patients all the time where I don't think it will work. The low-profile gastrostomies is kind of bringing back something that's been around since 1981 for better patient acceptance. Patients like it better than they do. Surgery can be safe in ALS if you use the right anesthetic management. And suprapubic catheters is something as simple as maintaining a better quality of life, of getting out and about. Overall, though, if the diaphragm's moving, you're breathing. That's what we all want to do, is maintain breathing, hopefully without the use of a ventilator. And as Steve said earlier about certain diseases, and I've treated a lot of diseases. ALS is one of about 20 different diseases I'm looking at, is nobody wants to go on a ventilator. Nobody who I've ever gotten off the ventilator has said, let's go back on the ventilator. The noise of a ventilator, the problems of a ventilator are significant. And if we can at least delay that even as much as a year for ALS patients, it's a significant improvement in quality of life. And again, I'm sure they'll post this on their website so you can look at all the slides. I apologize for talking so fast. Fortunately, there's not a translator committing suicide here, but I'm sure it was very hard for many of you to understand, and I apologize for that. But I thank you for allowing me to be here. Thank you for allowing me to be part of this strong community of patients that we're trying to treat ALS patients. Thank you.